conditions. If they're taking a medication, they've got a condition. Most commonly, it's going to be a 1-year certification in the cardiac section, in the psychiatric section, in the diabetic section. If they're taking something like Prilosec, they can have a 2-year for that. If they're well controlled with taking Synthroid or levothyroxine for a thyroid condition, if they're well controlled, well, that can be a 2-year. Your cardiac, which is an important section. Psychiatric, because some of the medications are concerned. Diabetic, well, that's a major concern. Those are most commonly, in general, a year or less. Many arrhythmias result from other underlying diseases, cardiopulmonary, which could be in themselves disqualifying. Okay, I'm skipping through a few things there. You may read through. Ventricular arrhythmias carry a greater risk of sudden collapse. Only certify ventricular arrhythmias if they're asymptomatic, no other disqualifying conditions. If they've had a medical certification from a cardiologist, and what? Their ejection fraction is at least 40, your magic number there. Okay, there's coarctation of the aorta. A lot of these conditions, if they're mild, you're not making a determination if they're mild. Their cardiologist is making that determination. But if they're being surgically operated on, again, that'd be 3-month waiting periods. Septal defects, again, that's a 3-month waiting period. If they get that thing fixed. Remember the tetralogy of Fallot? Oh, I remember that from board exams. Again, a waiting period of 3 months. Transposition of great vessels. I've had a couple patients with that. They weren't DOT patients. Actually, one of them was. Sorry, one of them was. Had that done when they were very young. Had no problems ever since then. But had the procedure done, doing wonderfully from that. But boy, do they sound weird. That's abnormal. Ventricular septal defects. Again, these they're even AAA. Well, I have a AAA. Okay, this might look kind of similar and familiar to you. So if it's greater than 5 centimeters, then no. Or if it's increasing, 0.5 centimeter increase inside 6 months, no. With surgical repair, waiting period 3 months. Same thing with thoracic aneurysm. And of course, we can see some of those things on our x-rays as well. Let's see, deep vein thrombosis. Do I have that one right here? Pulmonary embolism. Chronic thrombotic venous disease. Varicose veins are okay. They can be recertified for 2 years. Those are more superficial, right? They're not deep. Superficial thrombophlebitis, same as varicose veins. Heart transplants, there you go. Heart transplants. Waiting period, 1 year. That's on your sheet, under waiting periods. And medical consult should be a recertification of 6 months. Of course, a lot of different medications for cardiac conditions, often for either beta blockers, blood thinners, also blood pressure medications. There's your Coumadin morpharin down there, anticoagulant therapy, waiting period 1 month. And kind of gets back over here to our understanding that we need to communicate with one another. Okay, so this is risk factors for coronary heart disease. There are modifiable and non-modifiable risk factors. And yes, you may use modifiable and non-modifiable risk factors as parts of your determination to certify. You may decide, I said this before, but if the person walks like a heart attack and talks like a heart attack, looks like a heart attack, you can somewhat treat them like a heart attack. You can reduce their certification, even though perhaps their blood pressure is normal ranges. Perhaps their blood sugar is normal ranges. Perhaps a lot of the other things are normal. But you may reduce that certification. That is your prerogative and your discretion as a medical examiner. You just want to make sure that you are documenting those things. Can a driver who has an acute MI be qualified? Yes, provided that they have exceeded the waiting period of 2 months. This is right from sample training, by the way, sample training from FMCSA and or CME. Waiting period 2 months and meet recommended cardiac qualification criteria. Medical examiner is provided with medical reports, records, including cardiologist report indicating congestive heart failure, and the driver has an ejection fraction of 38%. Can he be certified? No, because the ejection fraction should be at least 40%. What criteria must the driver meet with a known diagnostic congestive heart failure? Must be asymptomatic, having no ventricular arrhythmias, having a left ventricular ejection fraction greater than 40%. Okay, there's a AAA. Driver has a AAA, and it's a 5.3. No, because it must be less than 5. How they've had that thing repaired? It was at a 9 4 months ago, and it's been repaired. Well, yes, for up to a year, but there's a 3-month waiting period. A little review: hypertension, no longer than 1 year certification. Myocardial infarction, 2-month waiting period, 1 year certification. PCI angioplasty, 1 week waiting period, and then up to 1 year certification. Coumadin, 1 month waiting period, 1 year recertification. Angina, 1 year certification. Heart transplant, 1 year waiting period, and 6-month certification. Okay, so here's a scenario, cardio scenario. Had CABG 6 weeks ago. He's taking aspirin daily, and he had CABG 6 weeks ago. Driver states he feels 10 years younger since the surgery. Hey, there are people that do. They get the artery bypass, and man, they just feel wonderful. Not everybody, but a lot of people do. Included in the cardiologist report dated 3.5 weeks post-CABG surgery is clearance for driving, return to work letter. That's nice. Driver denies any post-surgery episodes of angina. Driver also tolerates low-dose aspirin with no side effects that interfere with driving ability. And so we look through the exam. You should notice several things that we look down. Okay, so height and weight. We'll probably talk about some things there, but let's get down to the vision. 20/50 on the right, 20/25 on the left, and both together 20/25. Is that a problem? Oh yeah, it's a problem. It's uncorrected. There's no mention of glasses there. It needs to have 20/40, right? So this person needs to probably get some glasses. Hearing is fine. Looks like his blood pressure and pulse is fine. Urinalysis there looks pretty good. And left ventricular ejection fraction not included in the medical reports. And auscultation, there's an S4 gallop, so there's an additional sound. Remember, you got S1 and S2 sounds. And S4 gallop heard best around the sternum as a median sternotomy scar consistent with recent surgery, and the rest was pretty unremarkable. Well, bottom line is this person did not have a 3-month waiting period, and then there's also no other results from no other records. You know, this person has had no other testing done, left ventricular ejection fraction, none of those things. So also, as an S4 gallop, might have that, and maybe left ventricular hypertrophy is possible there too. So that person should not be certified. So this was kind of gross, and this is sebaceous cyst I believe we found on a patient. You're going to find some interesting things on folks. It was not cancer or anything like that, but referred them out for additional work from a dermatologist. What should you do to prepare for your exam? Well, make sure you're going through these exams. You can't actually perform these exams today, but you can certainly practice those. Of course, start auscultating, right? Advisory criteria, go through sample training that was provided in your materials there. The slides, quick reference sheets, start working through those. Get your eyes on as many test questions as you can. So what can you charge? You can charge whatever you want, by the way. You can get your forms. We get our cards, our self-laminated cards. We get ours from J.J. Keller. I know that ProHealth and some of those folks, they get their cards. I don't remember which one they get them from, but you can get these from lots of different places. Self-laminating cards. You can actually, you can purchase your long forms from other places too, or you can get a program such as 3B Exam, which that's what I would certainly recommend you do, or you can also print them directly off of FNCSA's website. And actually, in terms of, they can bring in their optometrist exam to you from what they use in their office there. Sometimes you need to call and get a little bit more clarification on some things there. Should I print out the FMCSA guidelines? I wouldn't, because those are often changing. And marketing those services, this is not a marketing seminar, but still, there's lots of good ways to put flyers up, and some of the trucker gas stations, I do not put up flyers for other services. But these services where truckers are out and about, they are needing your service. That's the place that they go. That's the place that they live. Besides their truck, they live in some of those gas stations. So that's totally appropriate for DOT exams to perhaps put a flyer in some of those places. So there's lots of different ways to market those things. I'd also say that I think it's quicktransportsolutions.com. I want to look up something here real quick, see if I can find something for you, which is a very trucking companies. Okay, quicktransportsolutions.com. So good. I'll just very briefly show you something to do here. We send out quarterly to employers a little bit of a page on advertisement on what we do, a little bit of an educational bit on new changes within FMCSA. And so you can go to quicktransportsolutions.com, click on your state. Bam, I've clicked on Nebraska because that's where I'm at. And the town where you're at. So I'm going to go to Hastings. Let me just go to H here. Where are we going? There it is, H. And you can go to Hastings. So now this is cool. You can see all the companies, trucking companies, in your area. So that's neat, right? You can do that wherever you're at. This is pretty neat. But not only do you see all these companies, but let's look at this one here, this Becker Transportation. Not only see the name, you also see the fax number. So that's nice. And then you also see how many trucks, how many drivers are there. So if this here's Becker Brokerage with 1 driver, and Becker Transportation with 28 drivers, who am I going to focus more attention on? Probably this person. And so my staff, we have about every quarter, we'll come up with this little educational piece of paper, advertise our services, and to almost everybody on this list, with a couple of exceptions, we will fax out. My staff just has all these numbers, puts in the fax machine, types in all these different fax numbers, hits send, and these are all sent out. Doesn't cost us a dime. Doesn't cost us a dime to do that. Super easy to do. Quick Transport Solutions. Good site perhaps to do that. Okay, as we move forward here, because I don't want to spend too much time on marketing things because we have lots of stuff to talk about. Well, on to the lungs. So a good question to ask regarding lungs. Do you smoke? How much? How long? Do you feel shortness of breath when driving? Do you cough frequently? Is it productive? Do you experience tightness in the chest while resting or during exercise? Do you snore or fall asleep during the day? Do you wheeze during the day or night? An examine to determine the presence of chest wall expansion, postural abnormalities, use of accessory muscles, breath sounds, dyspnea, cyanosis, tachypnea, elevated respiratory sounds, clubbing of the fingers. Any abnormal findings may require further testing, consultation with PCP. Dyspnea, which is shortness of breath, 85% of all cases of shortness of breath, and this is the point, I know that you have patients who are coming into your office who, from walking just from the front office, all they're doing is walking. They stand up out of a chair in the lobby, and they walk back to your room, and they sit down, and they are huffing and puffing. Or they go from your chair to your exam table. Lay down. You can hear it. There's some shortness of breath. 85% of those. Asthma, congestive heart failure, COPD, pneumonia, cardiac ischemia, interstitial lung disease account for 85% of all cases of dyspnea. So So if you hear somebody with shortness of breath, they've got a condition. And so that is worthwhile you doing some testing to check for that, to auscultate, of course, or perhaps doing some other testing. So orthopnea, which is dyspnea experienced when lying flat, that's why be one reason why they're having trouble sleeping at night, why they have to keep sleeping in a recliner. It's often a symptom of a much larger problem. So regarding abnormal respiratory sounds, wheezing and rhonchi, hoarse, rattling sounds or high-pitched sounds, pulmonary rales, marked total loss or diminution of breath sounds in any part of the thorax. Remember all the egophony and bronchophony and the 99, the EEE, and all these things. You're really trying to check for pulmonary consolidation. We're trying to, that's really the reason for doing egophony and bronchophony. And, ausculting one side versus the other, bilaterally checking those. So all these could indicate pulmonary consolidation. A driver presenting for his medical exam reports being a smoker and out of breath often. What do you do next? So this is a respiratory question, and the answer is you order a spirometer test. You may not do it, but you order it from somewhere. And so if you have somebody who says out of breath often, that's your answer, spirometer test. So again, there's lung sounds you can get your ears on. Certainly recommend you do that. Conditions of concern, emphysema, carcinoma, tuberculosis, chronic bronchitis, sleep apnea. We'll talk about sleep apnea here in a bit. The driver's condition may affect his or her ability to safely operate CMV. They must be referred to a specialist for further evaluation. So the three tests that are used in the pulmonary function section, again, there's a little box down there. Spirometry is number one. Second would be your pulse oximetry, which is, where's he at? I am here somewhere. There you go. This guy, right? Pulse oximetry, pretty easy to do. And then your arterial blood gas, which you probably will not do in your office. I would doubt it. It's going to be done in a hospital setting. So, regarding lung function tests, spirometry, total lung capacity refers to the amount of air contained in the lungs at the end of maximal inspiration. Forced vital capacity is the maximum volume of air that can be expelled with forceful effort following maximum inspiration. And your forced expiratory volume 1, which is the amount of air that can be forcibly expelled during the first second of forced vital capacity. You will use FEV1 and forced vital capacity, FVC and FEV1 the most. Those will be used in your pulmonary assessments. Whether you are talking about DOT exams or any other aspect of pulmonary function evaluation, those two right there are going to be used the most. Your pulse oximeter, 95 to 99%, and this measures the amount of oxygen, basically, oxygen saturation. Okay, and normally when you turn that little guy on, it should be around from 95 to 99% is considered normal. 92% for DOT purposes. This is a screening test, often prior to doing either spirometry or doing the arterial blood gas. It's easy to perform, non-invasive. We use this on every patient. It's a good test to assess for basic oxygen saturation levels as well as pulse. Pulse wave, too. You can actually see the pulse on there, so it's kind of educational for patients. It's not a replacement for arterial blood gas, which is also measuring oxygen concentration, but arterial. It's obviously a much more extensive test, a better test overall. This is a screening tool prior to the arterial blood gas. The pulse oximeter can have false positives, such as if you have cold extremities, callous skin, sensor replacement, etc. But some of your magic numbers. So I already gave you and you can see on that, your little square there. So your PO2, which is your pulse oximetry there, 92%. 92% is your magic number on your pulse oximeter. These things, I don't know, are around anywhere from $30 to $50, somewhere in that range. Maybe $80 if you get a real high class one. And again, I think Pink, you can get one from Pink pretty easily there. The other number is your forced expiratory volume. 65, that's your magic number, your forced expiratory volume. Forced vital capacity is another one you might want to know, which is 60%. And really, you're screening for different obstructive and restrictive conditions. But in your chronic obstructive disorders, definitely your FEV is going to be reduced. Forced vital capacities may be reduced as well there. Those are two most commonly used pulmonary spirometer values that are measured on a very routine basis. And the last one is the arterial blood gas. That one's a little variable. I think I have written that I do 60 on that on your sheet. But that is variable depending on the altitude that you're living. But the arterial blood gas is another test that's used quite commonly. So if a forced expiratory volume in the first second of forced expiratory volume is less than 65% of the predicted arterial blood gas measurements should be evaluated. And some pulmonary function test. Your pulmonary function test is the best overall pulmonary function test you do, better than the arterial. I mean, in terms of it's better as a screening tool. It's less invasive. It's your first stop in pulmonary function assessment. Gold standard. Note smokers that have a high incidence of COPD, yet individuals may have a significant reduction in lung function without symptoms. This is from FMCSA handbook here. Spirometry should be performed in all smokers over the age of 35. That has been a test question. I do not necessarily do a spirometry on every smoker over the age of 35, but you need to at least know that for the sake of testing. Kind of reiterating the same things there. This is an individual that came in. I'll try to stop after this scenario. This individual came in and looked about like this. This isn't him, so I did change his to a different picture, but looked like this. Color was bad. Remember all your pink puffers and blue bloaters and all those type of presentations. Hypertensive, so I was thinking about giving him a 3-month certification, but I was out of breath, so I went ahead and did a spirometer test. And sure enough, if we look up here at his predicted value on his forced vital capacity and forced expiratory volume, look at those two guys, 42%, 36%. Wow. What's the FEV? What's that supposed to be? 65. What's this one supposed to be? 70, right? 65. So, I mean, we've got some serious reduction in pulmonary function there. I'm sorry, 60%. On your forced vital capacity and 65 on forced expiratory volume. Serious reduction. And so this person, when you did actually the computation, because you can put that stuff in an equation, and you find out this individual, who was 59, had a lung age about 125 years old. This guy's not in good shape. So I ended up sending them out. I ended up disqualifying him, and he was the one that his employer said, well, we checked, and actually he's grandfathered. Well, that's cool. You're gonna, he's hypertensive. He basically can't breathe. He's continuing to smoke. He doesn't care. But you're gonna let him drive. Okay, well. So I documented that, and so that was a state thing. He didn't drive outside the state. Here's another individual came in. After this one, I will stop. Came in and he had he's about 390 pounds. And this individual, we did some blood testing on him. We did a sleep study on him. You can see he's diabetic at 7.4. His A1C, his glucose is high. His thyroid is a little bit on the hypothyroid side. His vitamin D, of course, was low. Some little bit of inflammation as well. And this was in 3 weeks. In 3 weeks, he went from a 7.4 as A1C to a 6.2. 3 weeks, he also lost 20 pounds. Spirometry results, because he also, here's his sleep apnea test. Over 30 is called extreme sleep apnea, and so he has extreme sleep apnea. He was falling asleep at the wheel. So we got him a CPAP machine. He's doing wonderfully, by the way. But also, even before he got the CPAP machine, in terms of these numbers, all before he got the CPAP machine. And even that, we put on a clean diet, exercise, gave him some different nutrients and things. And again, this is a treatment protocol seminar, but we did do several things, some berberine, some B, some vitamin D, because he was clinically low. Put him on a good diet, fat loss program. And so we came back. Oh, this is spirometer results. Originally was at 54 for his forced vital capacity, right there. Remember that should be 60, at least 60. And forced expiratory volume, it should be at 65. And then this is just 3 weeks later. He's up to 73 and 76. Had some significant improvements there. Lost 20 pounds in those 3 weeks, and 3 weeks his body mass improved dramatically, fat index, all those kinds of things. So diabetic numbers completely reversed. His thyroid numbers improved, his lung function improved, his energy improved. Daytime sleepiness, of course, I don't have that anymore. Now he's using a CPAP machine. He's just doing fantastic. And actually, is in 6 weeks, he lost 40 pounds and totally normal now. Spirometer results, doing wonderfully. So that was on a DOT exam. So here's 2 months down the road. His A1C at 6.1. Testosterone, I didn't show the original. His testosterone was at like a 230. He went up almost 100 points on that. And so a lot of good improvements. 41 pounds down from 390. He still has a way to go, but he's had tons of improvement, doing wonderfully. Called back and was so ecstatic and was tearful and speaking with my staff and just was very complimentary of all the help that we had provided them and how supportive the staff was to them as well. A lot of good things you can do with folks. But the spirometry helps push people towards better health because you can actually show them that, hey, I'm not making stuff up here. You're in bad shape. And actually using spirometry is a good way to help with smoking cessation when you couple that with counseling as well. So you don't have to do a spirometer test in your office. You don't have to do it. You don't have to do it. And there's lots of other physicians' offices that don't. But through the DAPC program also, you could take a class that helps you to learn how to do those as well. But still, spirometer test is a good test to use, and you need to at least know when you need to refer people out for those tests. Okay, let's take a 10-minute break. 10-minute break.